Chandru, can you request AB quickly?
Okay, sir. Sure.
Right.
Good evening, Kanax. Good evening, Chandru.
Good evening, sir. YouTube on live, sir. Good evening.
With the permission of the faculty, we'll start the session 6 in the evening. On behalf of the Chennai City branch, I welcome all the senior faculty. With your permission, I'm going to mute all so that it becomes quiet. Good evening, dear friends. It is a very important occasion for the Chennai headquarters branch of the ASI. It is one of the most prestigious orations of Chennai City branch, has been instituted under the name of Professor S.M. Chandramohan, and it's an annual event, and it goes to one of the two important aspects of the surgical profession. Professor Chandramohan has been an ardent foregut surgeon, has been an ardent educationist, and ardent has been promoter of various research activities. So on surgical education or foregut surgery remains the most important impetus of this oration for this evening. And we have the eminent leaders of the ASI, Professor Abhay Dalvi, the national president of the ASI, joining us as the chief guest for the evening. We have my co-colleagues in the leadership of the Chennai City ASI, Vice Chairman Dr. Chandra, Dr. Uttakumar, Secretary, Dr. Kannan, Treasurer, and one of the very senior most eminent leader of the ASI, and has been instrumental in organizing multiple courses in combination with the Indo-UK collaboration of the Edinburgh. We have Dr. Sai Krishna Vittal. We also have other eminent faculty from Jabalpur, Professor Dhananjay Sharma, who's been always associated with Professor Chandramohan for almost 3 to 4 decades of his career ahead. And we have the representation from the family. We have Professor Rama Chandramohan, the spouse of Professor Chandramohan sir, to be part of us. And with that, we will now call the session in order. And I also warmly welcome the delegates and the senior faculty members who have joined us in the YouTube. Let me quickly run through the plan for the program of this evening. I will be briefly introducing Professor Chandramohan sir, followed by there will be a brief chief guest address by Professor Abhay Dalvi. And after his address, he will be introducing the orator for the evening, Professor Palababu Rajesh, the Vice President of the Royal College of Surgeons of Edinburgh. And then Professor Palababu Rajesh goes to the oration. In principle, we do not take questions after the oration, but being a very important initiative of Indo-UK surgical training, I'm sure we will have very pertinent questions on training aspects or research aspects, or what next for people who have been thinking about education and surgical career in the United Kingdom. So with the permission of the orator and the senior leadership of the ASI, I would request them to allow a few questions to Professor Rajesh, so that the questions are taken in the right perspective. And at the end, we would request the family of Professor Chandramohan, Professor Rama Chandramohan, to give a word of thanks. And then at the end, we have the vote of thanks from our treasurer, Dr. Kannan. This will be the plan for the session. And with that, we call the session into order. Now, I would request Dalvi sir to formally inaugurate the program and give the chief guest address. And for your kind information, we have few press delegation also joining us for covering this program. Can I request Professor Abid Dalvi sir to first give the chief guest address and inaugurate the program? Over to Dalvi sir.
Thank you, Dr. Kanaguel, the president of Chennai City Chapter. It's a great privilege for me to be the chief guest for this Dr. Chandramohan oration. I interacted with Dr. Chandramohan a few times, a wonderful personality, good at heart, and it's not only a personal loss, but loss to the Association of Surgeons of India. So first of all, on behalf of Association of Surgeons of India, my condolences to Madam. And also, it's a great thing that you have done to start an oration in his name, which will be delivered by none other than a person who educated himself in Chennai, now based in the UK. So thank you so much for inviting me as the chief guest. And should I go ahead and introduce?
Sir, we will introduce Professor the oration, sir. Then you can come back to introduce the speaker.
So I'll say that let the oration be started. Thank you.
Thank you, sir. Now, let me have the honor of introducing the oration. Me being associated with Professor Chandramohan for the past 3 decades, I take the privilege of introducing Professor Chandramohan. Professor Chandramohan is the director, GA Surgery, Institute of GA and HPV Sciences at Global Health City, Prayar. And when he was at the last aspect, he was the International Academic Affairs Director at the Sri Ramchandra Institute of Higher Education and Research. His former careers has been, he was the former Chief of Surgical Gastroenterology, Director, Center of Excellence for Upper GI Surgery, Rajiv Gandhi Government General Hospital, Institute of Surgical Gastroenterology, Madras Medical College, Chennai 3. He was the founder president of ESO India, an organization which actively participates in research and patient support network. Dr. Chandramohan had a very illustrious career across his span. He received his medical degree in the year 1979 from the Tanjavur Medical College in Tanjavur. Professor S.M. Chandramohan completed his MS training at Madras Medical College. He was the gold medalist for the year 1984 from the Madras University for his highest score in the entire state in MS exam. Later, he completed his responsibilities on the primary health center of the Tamil Nadu Government Services for a group of about 47 seaside villages of Tanjavur district. And he was the very early students of the prestigious MCH Surgical Gastroenterology program at the Madras Medical College under the leadership of Professor N. Rangabashan. He was the 7th person to qualify with the MCH Surgical Gastroenterology in the country. He was the founder professor of the Department of Surgical Gastroenterology at the Institute of Non-Communicable Diseases of Government Roypeta Hospital and Government Kilpak Medical College in the year 2000. He was later promoted as head of the Department of Surgical Gastroenterology, where he ascended as the director of the Institute of GI Surgery. For the first time, the institute was upgraded to the institute. Professor S.M. Chandramohan's clinical interests include surgery for foregut disorders, for both benign and malignant esophagogastric disorders. He has special interest in the management of gastric cancer, epidemiological aspects, translational research, newer operative strategies to optimize the outcome in gastric cancer patients, and management of postoperative complications. His technique of coloplasty for reconstruction, using stomach for reconstruction in the presence of antral stricture, and various conduit enhancement strategies, various neck anastomotic strategies have become a global renowned techniques. The new concept in surgical training and education have been a major focus of his educational interest. He has authored more than 300 scientific presentations papers, editorials, textbook chapters, abstracts, and video productions. He has been on the board of governors of the Indian Association of the Surgical Gastroenterology for the last 5 years. He is also the permanent scientific council member of the International Gastric Cancer Association, International Society for Disease of Esophagus, and is all been covered up as a distinguished fellow of the American College of Surgeons. And later he was awarded the fellowship of the Royal College of Surgeons of Glasgow as addendum. He has won multiple awards. To mention a very notable international ones, the Japanese Surgical Society Travel Grant, the Travel Grant for Best Paper of the International Surgical Society for Disease of Esophagus, the Travel Grant for the International Gastric Cancer Association for the year 2011, the Travel Grant of the International Society for GI Oncology for the year 2009, the travel grants for year 2002, 4, and 7 for the Japanese Association of Thoracic Surgery, and later the Japanese Surgical Society Travel Grant for the year 2009. He was the Director, International Academic Affairs at Sri Ramchandra Institute of Higher Education and Research prior to his untimely demise on 6 July 2020. Ladies and gentlemen, the leadership of Chennai City branch and the entire surgical fraternity takes pride and honor in instituting one of the most important orations of Chennai City branch 5 years before in the name of Professor S.M. Chandramohan. And this year, we have the honor of having Professor Palababu Rajesh to give the oration. Can I now request Professor Dalvi sir to read the citation for the orator? Dalvi sir, please.
Thank you, Dr. Kanagwal. Mr. Palababu Rajesh is a consultant cardiothoracic surgeon at Birmingham Heartlands Hospital. His interests are minimally invasive thoracic surgery, surgical training, and education. He set up the video-assisted thoracoscopic surgery service in the Regional Department of Thoracic Surgery, which is now a renowned center for training in the UK. He is the lead examiner of the Joint Surgical Fellowship Examination in Cardiothoracic Surgery in Asia. He has been on the council between 2012 and 2017 and served on several committees. He is a member council in the European Association of Cardiothoracic Surgery. In the 513-year history of the Royal College of Surgeons of Edinburgh, a surgeon of Indian origin was recently elected as its vice president. An alumnus of Madras Medical College, that is MMC, Dr. Palababu Rajesh plays an important role in international affairs of the Royal College of Surgeons of Edinburgh. It was time that India had standardized the postgraduate medical curriculum. Dr. Rajesh is a resident of Chennai, completed his MBBS from MMC in 1974. He left for United Kingdom in 1976. After being involved in the Royal College of Surgeons of Edinburgh for 30 years in various roles, he was elected as its vice president. The new administration was inducted in November 2018. The Royal College of Surgeons of Edinburgh is the oldest surgical college in the world and has been in the forefront of surgical education, training, and maintaining standards. It has a membership and fellowship of surgeons in the world. The number at present is around 26,700, including around 1,500 to 2,000 Indians. On an annual basis, the college offers 100 courses both in and outside the UK and conducts around 44 examinations, both surgery and dental surgery, across the world last year. Dr. Pala has 130 original work as indexed publications, 3 translational research projects under his leadership, and his articles have been cited for about 1450 times. Considering his human achievements, contributions to academic surgery, and international initiatives in furthering the surgical education, the leadership and surgical fraternity of Association of Surgeons of India, and I may add as the past president of Indian Association of Gastrointestinal Endosurgeons as well, where I had seen him, takes pride in bestowing the honor upon Professor Palababu Rajesh the honor of being the prestigious Professor S.M. Chandramohan Orator for this year 2021. Thank you, Dr. Kanagwell. Welcome, Dr. Rajesh, and you could please start your oration. Thank you.
Sir, please unmute yourself, sir.
Thank you very much, Professor Dalvi, for those kind words. And at the outset, if I can say that I do miss Chandramohan. Chandramohan was a delightful personality, an extremely motivated educator, and an excellent technician who had the insight to train himself and to train others in doing what was complex operative procedures in the upper GI tract. I came across Professor Chandramohan through my trainee, Sridhar Ratnam, who used to tell me, Mama wants to meet you. And I had the opportunity of inviting Professor Chandramohan to Birmingham, where I ran an annual cardiothoracic surgical course for trainees and recently appointed consultants for the last 21 years. Chandramohan came and spoke at that meeting along with another senior, very close friend of mine, Professor Rajan Santosham. The friendship grew, and we met again at the European Society of Thoracic Surgeons, which I had co-hosted in Birmingham several years ago. It is a honor and a privilege to be in a position to do this oration on behalf of the Royal College of Surgeons of Edinburgh. Thank you very much. I just share my screen at the present time. So I've been given the task of speaking to the audience today about the pathway to surgical training and career options in the UK. At the introduction, I would just want to clear what is sometimes a problem with understanding the pathways to surgical education. A syllabus is a content of the curriculum. The syllabus consists of certain prescribed subjects during the undergraduate course or the postgraduate course studies, which are mandatory. A curriculum is run by an institution. It's either a college, like the Royal College of Surgeons, which is mandated by the General Medical Council to deliver postgraduate education, or a university, as is the case in several countries across the world. However, a curriculum is an aggregate of courses. It involves not just the syllabus, which is a part of the curriculum, but other courses as intended during the iterative process of completing your training in this chosen specialty in surgery. Now, to deliver the curriculum, you need an administrative body. The UK model consists of several layers of administration. The Joint Committee of Surgical Training, which is called the JCST in the UK, is responsible for writing the curriculum in all of the 10 surgical specialties. The Joint Surgical Committee is answerable to the overarching Joint Surgical Colleges meeting, the JCSM, which consists of the 4 Royal Colleges in the United Kingdom. The JCST then has the duty to inform the 10 surgical specialties, of which cardiothoracic surgery is one, to administer the training on the ground. And they are involved with the local deaneries. Now, the Joint Committee of Intercollegiate Examinations, again, the overarching responsibility to the Royal Colleges, administer the examination process, the assessments at the end of training. Now, the representation in the local deanery is through a regional training committee. The postgraduate dean of that particular deanery, of which there are 16 deaneries in the United Kingdom, is responsible for the delivery of the training in his or her deanery. Each surgical specialty is represented by a regional training committee. The regional training committee consists of a chairman, a training program director, an academic lead who's a part of the committee, an external liaison member to make sure that there is externality and the carrying out of all of these responsibilities are done with no vested interests. Each hospital which is approved for training has a educational supervisor who is a part of the committee. And most importantly, we have a trainee in the region who sits on the committee being elected by his peers or her peers. So there is a trainee representative because or she is an extremely important voice to be heard as to what they need by way of resource. Now, the curriculum is set up by the Joint Colleges Surgical Training Committee, and that is available on the website www.iscp/ac/UK. Now, that is the benchmark against which training is delivered. Now, how does one train or start training in the UK after he or she completes her undergraduate training? Now, the training program is divided into two tiers. One is the run-through program, which is surgical training year 1 to year 8. And the second one is called the HST program, which starts at surgical training year 3 to go on to year 8. So really, it's an 8-year training program after you complete your undergraduate course in the United Kingdom. Now, there is a further way of doing this by doing what is called core training for a period of 2 years. And the examination at the end of that 2 years is the MRCS, which is recognized as the starting point for higher surgical training. So the MRCS, you may wish to say, why do we have an MRCS when you're going to do an 8-year program in your chosen specialty, surgical specialty? But the core training is to give young people a taste for surgical specialties. Some of them may wish to drop out after the MRCS and go into interventional radiology. They may wish to go into other specialties because they really didn't think that that surgical career pathway which they chose is not for them. So this, if you like, is the postgraduate training program which is currently in vogue in the United Kingdom. Now, a themed program is one, especially in specialties like cardiothoracic surgery, in plastic surgery, where you have a subspecialist interest. If I can use my own specialty as an example, you would probably want to branch off as a pediatric cardiac surgeon, as an adult cardiac surgeon with a subspecialist interest in mitral surgery, in aortic surgery, or transplantation. or you may wish to become a general thoracic surgeon. So these, if you like, are the ways of getting into the themed programs. So how does this training for 6 to 8 years be delivered? Now we have the initial years program for 2 years, then the intermediate years for 2 years, then the final stages for 2 years. And during the final stages, you take your exit examination, and then your subspecialist interest is delivered. So you have professional behavior, you have leadership skills where you have courses in training the trainers, patient safety, and communication skills. We find that it's extremely important to make sure that the candidates who are undergoing this sort of training to be team players, because gone are the days of hierarchical medical um, professors, surgeons, because today it's a lot of team working. It is very important to communicate. And what do we understand by situational awareness? Where you know that there are some limitations and you need to understand your own limitations and make sure that you communicate with somebody else to help you. Especially if you're in an A&E department, you are looking at some emergencies and you find that this is something that you may not be able to handle. So that's the time for you to be aware that you have limitations, and what you need to do is to ask for senior help. And this is where it goes on to decision making, where do you operate? Will you wait? Is it the right time not to operate? Are there any investigations that you need to ascertain what you're going to do? So all of these things are very important. It's not just about operating, it's about holistic patient care. So in today's terms, how do we collect evidence? Because this is benchmarked against the curriculum. What do you do in your initial 2 years? What do you do in the intermediate 2 years? And what are you doing in the final 2 years before you complete to take your assessment examinations at the end of the 6 year training program? Now, how do you collect this evidence? This should be an ongoing program. This should be real time. So you collect pieces of evidence on a daily basis. Now, clinical evaluation exercise. What exactly does that mean? That means trying to watch when you see patients at the bedside by your consultant, who is your educational supervisor. How do you examine the patient? How do you examine the patient in the clinic? What do you do in the intensive care? So this is real time monitoring. A case based discussion. What exactly does that mean? You see a patient in the outpatients department for the boss in the next room. You collect all your information. You make a management plan. You come and sit with him in the clinic and inform him as to what you think is the right management plan for the patient. The boss goes with the trainee to the room, talks to the patient, and either agrees or disagrees with the trainee. But that case based discussion is very important. In the operating room, if the trainee is operating and if he finds that there is some aberration in the case, discussion with the boss, asking the boss to help him to get out of that situation, and recording what happened and reflect later about that particular event is extremely important. So that is a case-based discussion. Now, what is direct observation of procedural skills? These are, in my specialty, for an early years trainee to be in a position to insert a chest drain, to be in a position to put in a central venous cannula, to float a Swan-Ganz catheter, to be able to pass a bronchoscope in theater. These are skills, procedural skills, which are directly observed. And what is a workplace based assessment? Now, if the senior trainee is being requested by the boss to look at a patient, to collect all the investigations that has been done, talk to the patient, informed consent is obtained, the patient is then taken to the operating room, and the senior trainee is the operator with the consultant standing opposite to him. That whole episode is a workplace based assessment. Now, how does the trainee progress to this level? He progresses to this level simply because he's using the curriculum to benchmark his progress. He also comes to the educational supervisor, who will be his consultant, sits down with him at the end of the week and goes through this, and both the consultant and the trainee then fill an online assessment form. So the whole training ethos has changed so that there is a partnership between the trainee and the trainer. Now, audit is extremely important for the trainee at the present time. Why? Why do you audit? You audit because you want to make sure that you have quality improvement. Is there a standard, a national standard, as to how somebody should be doing a lobectomy for a lung cancer? Now, if there is a national standard, which we do have in the UK, now, do we meet that standard in our unit? Can we test it to see whether the unit is meeting those standards? If we are not meeting those standards, why is that the case? Is there a need for resource? Is there a need to improve the way he or she operates? Is there a problem? So if a trainee is initiated into audit, into self criticism, self reflection, it remains with him or her for the rest of his career. Now, the next evidence collection is clinical governance. Who is responsible in the hospital, in the deanery? Why is there governance, which, which is very important, simply because you don't want people to become mavericks. You don't want people to do some extraordinary things which is not safe for the patient. Because in all of these areas, patient safety comes first. We need to think very carefully that we are there only because of patients. If there are no patients, there is no profession. So the respecting the patient is the most important point that the trainee learns very early. So the role of audit, which I've alluded to, and the role of research. So there's a distinct difference between audit and research. Audit is looking at what is already in place and whether you meet the standards which are prescribed. Research is answering a question. If you look at some aspect of your training, you look at some clinical aspect, or if you look at some translational research, bench research, which you want to look at in a lab, that's the time to motivate these young people. That's the time to send them in those directions. If somebody has a penchant for research, help him. Try and see how you can put him in a lab. Try and see how you can grow this young guy so that he can become an academic. So these are the areas that are involved in the final years. Now, to make sure that all of the trainees understand the surgical guidelines produced by the National Institution for Clinical Effectiveness in the UK. Why are there guidelines? Is there quality improvement on a consistent basis? These are the areas for the trainee to understand and learn. So he's now come to the senior level. He has probably now passed his exit examination and is well on his way to obtaining a consultant's post in the National Health Service in the United Kingdom. This is the time for him or her to pick up a subspecialist interest. And the subspecialist interest is something which he or she gains, is motivated, and learns during his training period as to why he or she wants to do it. At the present time, in the specialty of general thoracic surgery, the video assisted thoracic surgery is really, really the glamour. People want to operate making tiny little holes in the chest, and it's got its own um, advantages. Patients go home early, patients don't have post-operative chest wall pain, and they can return to work fairly quickly. So this is very similar to laparoscopic surgery and now robotic surgery. So how do we train these young people to get to that stage? So you start with simulation. You start with simulation in the hospital. You have little simulation areas in the postgraduate center. And this is really to test hand-eye coordination, to make sure that you develop hand-eye coordination, and you go on once you get on to these, box trainers, which we call, where you put in little beads or little um, uh, pieces of chalk, pieces of anything you want, rubber, and try and see if they can pick it up and place it in another part of the box. So this simulation exercises at the beginning. Then you go on to dry labs with pieces of porcine material. You then move on to wet labs where you simulate with the help of technology to see if they can work with what is almost a live model. Once they've graduated to this state, which takes really about 6 to 8 months, you can then go on to a live animal model. And this live animal model in the United Kingdom is not possible because of a lot of restrictions. So we tend to normally take these young trainees to Europe, where we have access to labs both in France and in Germany. And we are able to train them to do all these live animal models. Once they come back and once they are in a position to operate under supervision with the consultant on cases which are of their interest, subspecialist interest, we then send them to approved centers in the UK or overseas for a period of 6 months to a year on fellowships. Now, at the present time in the UK, the relationship with China has been such that we send a lot of these candidates to Shanghai, to the pulmonary hospital. The trainees then come back learning new procedures, and to be in a position to transfer those skills into the NHS, what we tend to do is to have a proctor come across from these centers and help them to set up the process of doing these procedures on a regular basis. Now, it's very important that if the surgeon is training himself to get to this level of introducing new procedures, then he can't be in isolation. because the rest of his team need to know what he or she will need. So it's important to have the team involved. And how do we get the whole team involvement? We need to take them across to the center that he has been on a second trip so that they understand what their nursing staff do in those hospitals. The anesthetist can understand what exactly are the techniques, the tips, the tricks to do these procedures. And this is the way that we tend to help these trainees to achieve what they really, really want towards the end of their training program. So, this sort of assessment is a very systematic procedure for measuring a trainee's progress against defined criteria. Now, this defined criteria is what you have with the curriculum, if you see what I mean. So, it's an ongoing process from the time you commence training till you finish training that your training is blueprinted against the curriculum and supports the curriculum. Now, what is the purpose of doing all this? The purpose of doing all this is to evaluate whether the trainee is meeting the standards of competence which is specified in the curriculum, because he needs to know that he's progressing gradually and seamlessly towards the end. Now, it also provides comprehensive feedback as part of the learning process for the trainers, the regional training committee, the deans. If there are any areas which are difficult, it is not just for one trainee, but for a variety, for a section of the trainees, then it is for the trainers to provide feedback to the JCST to say that the curriculum needs changing, the syllabus needs changing. So, if you like, it's an trainer trainee engagement. Okay, so how do we know that these people have completed their training and are ready for the final um, examination? So, all of these ongoing workplace based assessments, these workplace based assessments cover knowledge, cover judgment, technical skills, and professional behavior, because there is a one to one discussion almost on a daily basis with the trainees. Then, how do we assess operative skills? That is with the surgical logbook, which is kept. Now, that surgical logbook will be signed off on a regular basis after a week in the operating theatre. Every week, at the end of the week, the consultant and the trainee sits down. They look at what he or she has done. Has she done or he done what is necessary for his year of training? For example, in my specialty, in year one, he or she should be able to open the chest. He or she should be able to take a piece of saphenous vein out as a conduit. They should be able to close the chest. They should be able to pass wires around the sternum and be able to close the chest and close the chest competently. So, if they are in year three or year four, can they put a patient on bypass? Can they make the um, purse string sutures to put in an aortic cannula? Can they go on bypass? And then proceed in the next session whether they can do the top ends of the coronary grafts and then proceed to do the bottom ends. So it's a very systematic way of getting them through a program where at the end they are competent. Most of the time, what we don't want to do is to say that they're brilliant. We don't need brilliant people, because brilliant people will do what they necessarily want to do throughout their career. What we want is competent surgeons who will take care of the patients, for the patients, on a daily basis. That's the most important thing that we need to understand. Now, we have two sets of examinations. One is if you are in a um, seamless training program, which is an 8-year training program, you start, but you've got to do your MRCS at the end of 2 years. Whether you're in a CT position or an ST position 1 and 2, you still take your exams or MRCS to be in a position to start your higher surgical training. And at the end of specialist training, you have an exit examination. And I'll come to that in a minute. So, what does the regional training committee do? The regional training committee gets you to sit down with your educational supervisor at the start of training and put down a learning agreement. Now, is this learning agreement reasonable? And is this learning agreement reproducible? And is this learning agreement achievable? These are the most important things that one has to know. Now, the learning agreement is invariably blueprinted against the curriculum. So it's not too difficult. And the educational supervisor should make sure that he or she, at the end of that period in time, say year 1, you are with Sai Vittal. So Sai Vittal's job will be to make sure that he or she has achieved what is blueprinted against the curriculum with that particular training. And then when he moves on from that year 2 to year 3, then you have a set of trainers who this person will be going to. And it's also very important to inform the audience today that no trainee is allowed to stay with one trainer for the whole of his training program, because it is important for them to be distributed in a rotational program so that they can pick up various things from various consultants and take the best for themselves. Because a lot of us have some bad habits which we don't know, and we continue to do it. You see, so this is one of the things that the educationists have brought in into the training system. So at the end of the year, there's an annual review of competence progression, which is called the ARCP. So the trainee has to come in front of the training committee with his evidence, collected evidence, with his surgical logbook and his other portfolio, or having attended courses, having done audit, having done any research. So all this is collectively looked at by the committee. Now, the annual review is very important because it not only gives the trainee a chance to say what he or she thinks of the year spent, but he also has an anonymous form to fill about his trainer. So it's not as though it is a given for each trainer or consultant to have a trainee. But if he or she doesn't train, the person who has been allocated to him, he or she will not be given a trainee next year. So that's very important. That it's not a given. You're not a big boss. You don't think that you can abuse the trainee. Having a trainee is a privilege, because you can have non-trainees in your unit who will do the mundane jobs on a day-to-day basis. But if you want to be a proper trainer, there is a norm which you need to follow. So that, if you like, is the role of the regional training committee. So this ARCP is a formative assessment of the period of time that the trainee has gone through to achieve what he or she needs to achieve. What does the regional training program director do, and what does the chairman of the regional training committee do? He has to go through the educational supervisor's report of that particular year. He has to look at the feedback about the trainee, because the trainee will be given a set of forms which he should distribute to a variety of people. This could be to an anesthetist, it could be to an senior sister on the ward, a senior sister in the theater, a colleague, and collect the feedback as to how he or she has performed anonymously. And those feedback forms are sent directly to the training committee and the ARCP. So, this is the whole training program in the UK at the present time. This trainee's learning portfolio at the end of year 6 is important for him or her to sit the exit examination. And in this talk, I've put FRCS general surgery, but the specialty fellowships are in all of the 10 surgical specialties in the UK. So the exit examination is only allowed if you have been through this 6-year program with progression, with completion of all of the contents of the ISCP. You have been signed off by the chairman of the regional training committee, and then you take the exit examination. So, in conclusion, the aim of the surgical program in the UK is to produce a surgeon who is safe, who is competent to practice independently in his or her own environment. Now, what are the career options that one has in the United Kingdom? So, the end of all of this training program, if you're successful, you are in a position to apply for a consultant surgeon's position in the UK. For a variety of reasons, you may not be successful in the program. However, you may fulfill criteria to complete some parts of the training. So you can apply for non-consultant grades, which are available in the NHS. Some people, for a variety of their own personal choices, don't want to be a consultant surgeon. They end up being an associate specialist. People who have, for a variety of reasons, not been able to get onto the training program have been unsuccessful in applying for the national selection, which takes place annually to get into a um, substantive training program, end up as trust grade doctors, associate specialists, non consultant grades. All of these people are extremely important for the NHS. During the recent pandemic, in April of last year, when a review was carried out, it was very interesting to find that a third of the people who work in the NHS are of non consultant grades, and they are a very important resource for running the NHS. How can we help in the college? We have an international postgraduate deanery, and we follow the uh, MTI, which is the Medical Training Initiative, which is a regulation from the Department of Health. We provide 1 to 2 year supervised fellowships in all of the 10 specialties of surgery. The training is carried out in the college's approved centers in the UK. Most of the trainers are or all people who are fellows of the college. We provide pastoral care. We inform the trainees. They go through a agreement, a learning agreement, and at the end of this 2 year program, they are certified. There are some very smart trainees from overseas who come and during those 2 years convince their trainers and their regional training committee that they are qualified to take the exit examination, and they have been successful. One lad comes to mind, Rajkumar Srinivasagam from Coimbatore, who is now back in India, having completed his FRCS general surgery and is now working in AIIMS in Rishikesh. So, we do have provision for helping a lot of young surgeons from overseas. Thank you very much for giving me the opportunity of presenting what is a snapshot of the training program in the UK presently. If I can have 30 seconds to explain the new logo, which has come out in the last couple of months. We are very proud that this administration managed to get this logo um, passed by the council. If you look at the logo, you see a unicorn. And the unicorn is a symbol of Scottish heraldry. And that symbol states that it's pure innocence and heals. Now, the horn, legend says, is that if there is poisoned water, the horn of the unicorn, when dipped in that water, the water turns clear. So that, if you like, is one of the new icons that we've got in our logo. Below the unicorn, you see a castle, which is reminiscent of Edinburgh. And in that castle, you will see it states 1505, which is the year that King James IV incorporated the barbers and the surgeons into the College of Surgeons of Edinburgh. And you see a sun, and inside the sun is the globe. So the sun is again the power of healing, and the sun doesn't set anywhere where a fellow resides in the world. Thank you.
Thank you, sir. Thank you for giving a very lucid view of the training program, assessment, and what are the ways to get into the to fellowship programs and the career. I'm sure we have few questions coming up. Let me quickly ask the comments of the leaders of the ASI. Dr. Dalvi, sir, please.
I think to be very fair, we have a very compressed 3-year course to become a postgraduate, considering graduation to postgraduation. And the National Board of Examinations and the National Medical Council, along with the Association of Surgeons of India, just today had a large discussion on how to go about. I think the system which is going to be advised to the government of India seems to be something which is similar to this, and hopefully we will be also able to impart complete knowledge to a surgical trainee before the trainee actually passes out to practice surgery. So a good knowledge for me to go ahead and discuss further if given an opportunity with the government and the National Medical Council. Thank you, Dr. Pala, Rajesh. Thank you.
Thank you very much for the comments, Professor Dalvi. I've been involved with Abhijit Seth. Abhijit has met me when I came to India in November of 2018, asking for some help with the curriculum. But I was supposed to meet him in Delhi in March of 2019, but unfortunately, due to the COVID pandemic, I couldn't meet him. And I know that Pawan Lal, who's also a fellow of the college, is involved, and he's been talking to me too. But any help that I can give the NBE, we will certainly do it, because I've had some discussions with the PMO's office, and they were very keen. And I'm pleased to see that there is a move to standardize and to make sure that whoever completes his or her training is competent to go out and help the public. I'm really pleased to hear that.
We are actually sitting in the Halsteadian era of residency system, which has to change. With so much of technological advances that have taken place, it's impossible to train the people in all aspects of surgery in just 3 years, which is not done. So we are, bringing out incomplete surgeons, which is at the end of my surgical teaching career spanning 40 years, it's not good. So I think since I'm in a position to be the president and Paunilal is a good friend of mine too, we are pushing this forward, and hopefully Parvinalal will take your help. If I require, I'll personally take your help. As I said earlier, I've seen you on the program of IGS as well, Indo-UK conference that you were present. And that time itself, I had thought that I'll catch you sometime. And I had this opportunity to catch you.
Very
Only
welcome.
you were sitting in the same place talking. Only thing at that point of time, I think your wife was also with you.
Thank you. Thank you.
Thank you, Dalvi sir. Do any one of the Chennai City branch leaders have any question to ask before we move on to the participants' questions? Dr. Chandrasekhar?
No, sir, no questions. First of all, our sincere thanks from our Chennai City branch office bearers and also the faculties and all the in behalf of all the medical college faculties of Chennai City and Tamil Nadu chapter. We learned so many things from the discussion today. So we will discuss officially with our team and what the further plan of execution of these curriculum changes. We'll discuss with our university also. So thanks for sharing your things to our branch. Thanks a lot, sir.
Thank you, Dr. Chandrasekhar. Dr.
Thank you,
Uttarakumar sir?
Rajesh.
Extremely very happy to see you, our Dr. Professor Rajesh sir. Extremely very happy, and our professors and other doctors are really good opportunity to interact with you, not only today, in future also. So thus we need of your email also. Not only the training program, any other investor where this also we can discuss with you.
Please.
That is the only. And also we have our doctors having the cutting surgeons having one question, they have the doubt in their mind. So what about this is a sponsor program, or they want to pay how much of Indian money, accommodation fee or anything? So many questions arises in our doctor's mind. This is kindly clarify. The sponsor or
Thank you. Thank you very much for your comments. You know, Sai, who has been on council and who's also very closely involved with the international committee of the college, will be my port of call in Chennai. You know, if there is anything you need, Kanagwel has my email. You know, you're very welcome to let me know if there's any way I can help, or I can put you in the direction of the staff in the college who will be in a position to help you. You know, it's not a problem.
Thank you, sir. Thank you.
Dr. Kannan?
Yes, sir. Thank you, respected Palababu sir. In fact, we are proud to have you as a Vice President of Royal College of Edinburgh, and you have given the overall view about the fellowship program. So it is, in fact, visionary for all our young surgeons, in fact, all of our younger colleagues and as well as our surgeons. So we are very much thankful to hear the excellent lecture about the fellowship program. Thank you once again.
Now, thank you, Dr. Kannan. Can I have the honor of listening to Professor Dhananjay Sharma, sir, please?
Thank you, Dr. Kanagwel. Rajesh, sir, as always, an excellent presentation. Always, sir. Always a pleasure. Sir, what you have enumerated is the structure. We do not have a dissimilar structure. Only thing is we have 3 years as against your 6 years. But the boys are working round the clock. I don't know if they get a free moment. 3 years practically round the clock. The emergency theater is running round the clock even during COVID times. And we have been able to successfully switch to online teaching, online simulation courses. We have conducted a couple of online boot camps also. And we have published several of these articles. So the structure is not much different, sir. Only thing is it is not so formal. Partly because everybody is, running ragged because of the overwork. And in the initial phase of the COVID, the private hospitals were not taking any emergencies. So our emergency theaters were running round the clock. even though at times the PPE kits were not there in adequate numbers. So I don't think we are much different from the training that way, but it is not so well structured. We'll try to incorporate that, like Dalvi sir has also said. Some of this we can do with that framework, that scaffolding, and that would certainly help us, sir. Thank you very much for those wonderful ideas.
Thank you.
Thank you, Professor Sharma. Now I'd like to have the honor of taking the comments from Dr. Sai Krishna Vittal, who has been instrumental in organizing various courses and liaising with the RCS for the welfare of the Indian surgeons. Dr. Sai Krishna, please.
Sir, vanakkam, sir. Pala, sir. Vanakkam.
Vanakkam, sir. Vanakkam.
Amazing talk. You gave such a fantastic insight into the pathways of surgical training and career progression in the UK, and I'm sure it benefited. Thanks a lot for talking to us Nambur Chennai city surgeons, sir. Sir loves to converse in Chennai Tamil. Professor Dalvi, sir, apologies for talking the vernacular. I just wanted to keep Professor Pala Rajesh happy. On a very serious note, I would like to echo and agree with all the sentiments expressed by Professor Dalvi and Professor Rajesh Sharma. I also feel 3 years is perhaps, although we work day and night or whatever, I think it should be spread over so that even the trainees have adequate time to learn and train, and they should enjoy those period of training. And I am glad that Professor Dalvi and my good friend Pavan are taking a step in the right direction. I would like to congratulate the Chennai City branch headed by Dr. Kanagavel and all his colleagues, Kannan, Chandrasekhar, Uttarakumar, and Chandrasekhar, for taking this initiative. I know Professor Chandramohan since probably 1990, perfect gentleman, and we really miss him. And thanks for Kanagavel and the Chennai City branch for taking this initiative. Thank you, Kanaks.
Thank you, Dr. Sai Krishna. I'm sure we will now take the questions from the delegates and participants in YouTube and other groups. One, Dr. Anshu Pratap, she would like to know from you, sir. She has completed her MS in general surgery, that is the 3 years program. She is keen in pursuing higher training in GA surgery as a specialty. According to you, she has understood we have an 8-year program. So does it mean trainees who have completed 3 years program have a lateral entry? Is there any option to do that, or they have to pursue from the beginning again?
Okay, the straight answer to that is that this young lady has completed a postgraduate training program in her own country. You see, the International Postgraduate Deanery is available to all the trainees across the world. So the first thing we do is to make sure that the trainee's country has a postgraduate program. If he or she is successful in completing a postgraduate training program in her or his own country, then the eligibility criteria of the International Postgraduate Deanery is available on the website. Now, she can come across to the UK and she can get into the training program that we offer, and she will be evaluated by her assigned training program educational lead. And based on what he or she is capable of, if this young lady is going to come across what she is capable of, then they'll put her in that year. You see, she will probably go into year 4 or year 5 and not start right from the bottom. So that evaluation exercise on arrival in the UK is crucial. Because, we don't know what happens in Saudi Arabia, what happens in Thailand, in the Middle East, somewhere up in West Indies. So we are trying to collect data to make sure that we can standardize the eligibility criteria. So we have a group of people in the International Postgraduate Deanery that when an application comes in, that is sent to all of us. We have the set eligibility criteria. Then we inform the administrative staff in the deanery that he or she is eligible. So they will then be sent an reply saying that they're eligible, and they will come across to the UK. They will meet their educational supervisor. They will have a learning agreement, and they'll get started in their training. Now, what happens normally is that people from a variety of countries from across the world come for training in their subspecialist area. Now, from India, we have people who have completed from the armed forces, really. I've had lieutenant colonels and wing commanders who have come across the UK to complete a specific subspecialty interest, in hepatic transplantation, in arthroscopic surgery for the shoulder. So they have a specific need. So it's either general training or specific special interest training that we are able to cater for. I hope I've answered the question, Connect.
Yes, sir. That has exhaustively covered. Thank you for answering this question. Now we move on to the next important aspect of examinations. In fact, now we have people from China, Nepal, and Singapore joining us on the YouTube. There have been queries, one by Dr. Oscar Chiang. Sir, he would like to know from you, sir, after the onset of the COVID situation, the overseas exams have all been temporarily withheld, and how early we can expect the exams, sir, because having completed, is that only possible to come to the UK for exams, or can we in near future look forward for an exam date?
Correct. We are desperate to be in a position to do this. Sai knows, and I take a lot of advice from Sai about when we could come to Chennai. And the international travel restrictions is one, and two is the satisfaction that a place where we're going to is COVID free. We are ready to get started. As far as the MRCS is concerned, in the UK, we have had examinations conducted with social distancing. But as of January of this year, everything has been suspended because of the second wave with a new variant until the middle of February in the UK. It may well be. I've had some discussions with the Director General of Health in Singapore, and it appears as though Singapore is reasonably okay. Malaysia isn't, and Hong Kong is. So I'm running the cardiothoracic exams on the 23rd and 24th completely remote. But that's something which we are learning. And the problem with running some of these remote exams, I've been examining in Africa, the IT bandwidth is something that we have to be extremely careful about. Because if there is a crash during the examination process, it's unfair for the trainee because he spent a lot of time, energy, and money to participate in this examination process. So I think we are extremely keen to get started as soon as possible. But I don't think we will be allowed to travel outside of the UK until spring, which will be March. We will. I will take that very seriously. And next Wednesday at the office bearers meeting, I will ask that question to the examinations department, and I'll come back to you, Connect.
Thank you, sir. Thank you. Sir, there is one question on the MTI, the Medical Training Initiative process. Is it open only if there is a GMC registered trainees can come in, or is there a lateral entry without an RCS program to have an MTI? That's been the question, sir.
Tambi, the answer is yes, because you have, if you go through RCS Ed, we get you the GMC registration and the visa. We work for you to get you a GMC registration and visa. And we take the what we call number from the MTI into the college. Now the trusts also are doing the same thing. Individual trusts to try and get good trainees from overseas also apply for the visa for that trust. But the problem with entering through that avenue is that that training is not supervised. And the complaint that we have had from several trainees is that they are left to their own devices. And at the end of the 2 years, they've really not been trained. They've been used as a pair of hands. They have not been, treated properly. And that's one of the reasons why the Edinburgh College took this on very seriously. And in fact, I was the first director of the IPD before I became vice president to insist that we must have a trainee trainer agreement, because there's no point in people, I know so many people take loans to come across. And I'm trying to see if we can set some foundations up for needy candidates who come across, to the UK. Anybody who's got merit must be, helped. They must be provided the resources to get better. So I think lateral entry is there, but I wouldn't really prescribe that. To be under the umbrella of an respected organization is better.
I understand, sir. That clarifies the
You see,
doubt for
correct. At the end of this 24 months, the Royal College gives you a certificate, because we have put some structure into that program. That every 6 months the trainer has to give a report to us, the trainee has to give a report, so that we know that they are actually being trained properly. And at the end of the 2 years, we give a certificate from the Royal College of Surgeons of Edinburgh that you have completed the training program. If you are so good that you can take the exam, then you can take the fellowship. But if you have completed satisfactorily a training program, you receive a certificate as well.
So then you can also be the post nominals of membership of the international
Yeah,
deanery.
absolutely. You're right, Sai. Thanks for reminding me.
Thank you, Sir, and thank you, Dr. Sai, for giving that vital inputs. Sir, the next question is from institute of, say, central government institute or a state government institutes, where people are already in their career, like a assistant professor or a senior lecturer. I would say the question is for a surgeon who's around 40, who would like to get trained on specific areas. As you in, maybe I can come through your specialty itself. You rightly pointed, people are very fond of getting exposed to the VATS procedure of various thoracic operations. So assuming if that is the demand or that is the expectation of a candidate to come into UK, say if he wants to learn exclusively minimally invasive colorectal surgery or robotic colorectal surgery alone, does it mean the candidate would like to know, sir, do we have standalone fellowships, and what is the way to apply for it, number one? Are we to fund for ourselves if we come for non-rotational fellowships? These are the two questions asked.
Okay. Connect to start with, the specific interest fellowship is available through the IPD. See, like I said earlier on, we have some people from the Indian Armed Forces who are there doing specific things. They've graduated from Pune, they've done their post graduation as well, they've done their CHM from Delhi, from the specialist hospital, and they've come across for a year or two, right? And they are doing just this. One guy is just doing shoulder surgery, minimally invasive shoulder surgery. Another guy is doing hepatic transplantation. So you can, if you like, get what you specifically want through the IPD. And the procedure is to go to the IPD website. International Postgraduate Deanery website in the college and request for information. And we will send out an application pack. You know, the administrator there is extremely helpful, you know. So Jeannie, her name is Jeannie Hislop Parsons. You know, she will send out all the application details through the IPD.
Thank you, sir. The next question for you will be on the financials. If somebody is going to come as a short-term fellow, is the candidate need to foot the bills for learning, or does he need to pay to the NHS the training fee? These are the questions asked for the training part of it.
Right. Okay. The facility that we provide is to join the NHS. So if you came to do a fellowship for a year or 2 years, you're paid the NHS salary as a trainee because you are, you know, in a slot which is paid for by the NHS. So you are given an NHS salary for the 2 years that you're there, 1 year or 2 years that you're there. The minimum period, I think, can still be 6 months. I'm not sure. But I think it is between 6 years, I mean, 6 months to 2 years. And unfortunately, Kanaik, at the present time, it's only to a maximum of 2 years because it's the Department of Health's and the immigration rules that they will not give a visa for more than 2 years. But I don't know what will happen with the pandemic, you know, with the job shortages, with the nursing shortages. I don't know whether they, and also we have now exited EU. So whether we'll go back to the Commonwealth, whether we will do other, you know, avenues to get people on board, I have no idea. But if I know anything, Sai will be the first guy who will know about it.
Thank you, sir. And we move on to the next aspect of the training. Sir, if someone, say, you were very categorically mentioned what the student does in year 1, 2, 3, 4, 5, 6, and 7, 8 goes to the sort of a super specialized area of work and they go on to become a consultant. Leave alone the financial part of it. You have very categorically said things what are not taught locally or given an opportunity to go overseas to learn that and come back to the UK to pursue the operation. I have a very unique situation. I'm sure many of my teachers of my age has a very unique situation. In fact, I did my post-graduation late 90s and the early 2000s. In fact, at Madras Medical College, the department did not even have a laparoscopic device at the late 90s. But to be honest, at least 70% of my work, both basic and advanced, are laparoscopic today. So my challenge was I had to make a point. In fact, I've been traveling across the globe, say not on a long-term commitment, definitely for a few months, spending time in the departments where they do specialized work and come back to do the work. The challenge is what I would very clearly expect as an answer is when we did first year of general surgery, we were given appendix, we were given hernia. Second year, we get to do abdomen opening closures or trauma laparotomies or basic surgeries. Third year, we ended doing few resections, thyroidectomies, mastectomies. I would say, of course, we did a lot of other procedures, but this is a sort of an elevation of your skill sets and how you learn. But at this present scenario, hernias are done by us with laparoscopy now. We end up doing colonic resections or trauma laparotomies or perforations by laparoscopy now. Let me be very honest. In fact, I am also sort of in a higher learning process of making my open surgery experience into a minimally invasive surgery experience. In the bargain, the hernias get lost or they are not available for the first year trainees. The resections, standard resections, a right hemicolon or a standard rectal surgeries, they become unavailable to the residents. I'm say if I'm going to truly be honest, my state of affairs is I would have done 30 to 40 colon resections. I would have done 40 to 100 fund applications. These are my experience levels. Truly on international standards, I'm still on the higher part of the learning curve to gain competence. Where and how am I to fit into the training program for my residents in this situation? How does the NHS look at this problem?
Correct. This is an extremely good question. You know, see, this is the problem we face in the UK as well. Now, as you said, I trained in open surgery, and then when I became a consultant, I went away and learned how to do video-assisted thoracic surgery as a part of a fellowship. I went to the United States. I spent um, time in 6 units and learned different operative procedures. Came back and started doing them, getting proctors from the US, from Hong Kong, and set the unit up to become a video assisted thoracic unit. Today, the kids want to go directly into minimally invasive. They don't want to do the open procedures because for them, their perception is different. And if you get the young kids who have finished medicine and are doing their core training, I was amazed because these guys play so many video games that their hand-eye coordination is excellent. So when you give them a camera and ask them, hold the camera and concentrate on where I am, they just do it whistling in the theater because they've already played all the games. So we are now looking at changing the curriculum because of technological advance. You know, laparoscopy is now become the starting point for these kids because robotics and advanced, training with a lot of new gadgets. The third arm in thoracic surgery where you just stick a retractor in and just leave it there so that you can operate with two hands. So all of these things are coming in, and I think that's what the interesting changes. I had to change, and if you don't change, you'll get stay stuck. So I think with technological advances, even the operative procedures will change. And you see, it's a very interesting point you made. If you say somebody should have done 30 open cases before he starts doing laparoscopic work. Now, the argument with the faculty in the UK is if we say that what we really, really want to do is to be helping the patient, looking at patient satisfaction, looking at patient safety, and getting people back to work as quickly as possible, less pain, less hospital stay, then we should use the technology available and make it better and better. And the NHS is also saying, whoa, whoa, hang on a minute. We guys don't have that sort of resource, fiscal resource, monies to provide you with this. But technology is driving it forward. And I think, my own personal view is that if you have bright kids, forget about doing open appendicectomies. Let them do laparoscopic appendicectomies because they are the drivers of change for the next generation, you know? And I'm sure, see, the costs of all these instruments used to be phenomenal in the
Early phase.
early days, but now the costs have come down because the volume has gone up. And because the volume has gone up, the device companies and the instrument manufacturers have cut the price down. I know that making a stapler in Connecticut costed $8, but they're selling it for $75 a piece. I was there helping them, doing some research with them for the thoracic instruments. So, the manufacturers won't find, that they are not sustainable. I think we'll have to drive it.
Thank you, sir. And one closing question. Many students, at least a few of my residents, have openly questioned me when I ask them to get involved in one part, some of other translational research activities or basic research activities. They have very clear vision. Sir, I would like to be on the clinical side. And I don't think I will be effectively utilizing my time if I'm sent to a, say, gene lab or a basic science lab for 6 months, learning about how do I do a sort of a RT-PCR being done, or so doing a research work on something on lung cancer or the esophageal cancer. How do we handle these modern kids who very clearly they want to be a clinician, and they know for themselves translational research is not their bread? I won't blame them. And it becomes a challenge to sustain the overall activities in the department.
You see, I completely agree with what you say. But you see, this is precisely what we are trying to say. It's not just about operating. It's not just about doing thousands of operations. It's about learning. You know, I assure you that if you start operating and doing nothing but operating and seeing patients, by the age of 45, you'll be burnt out. You'll be bored to death. You won't know what to do next. You know, if you know why you're doing something, you can actually help to make it better. For instance, when one of some of my trainees come to the operating room, they come past the catheter lab, the cardiac catheter lab, and they'll come to theater, and I'll just ask them, I believe there was an hot angioplasty going on. Did you know who it was? Yes, it's so and so. He crashed, so they took him to theater and the cath lab, and they've done a hot angioplasty. I just asked that guy a question: how many atmospheres did they use to inflate the balloon? He knows how to go in and where to put but he doesn't know how many atmospheres that the balloon is inflated to open that lesion. He does not know what that balloon is made of to be resilient, and when it expands, it doesn't burst. It's a drug-eluting stent போட்டாங்க sir. What drug is in that stent? What does that drug do? How does that drug prevent endothelial proliferation? That's the point, to think. And when you start thinking like that, there will be 3 fellows out of 10 who will say, I want to know more, so I will do it. I don't think everybody, see, I know when we were in MS, they used to have one dissertation. That is the most useless piece of work that everybody did. The last 2 months of the thing, you collect 20 cases, go to some library and fudge some of the other data, and then put it and give it as your MS dissertation. Useless, because nobody learnt anything with it. Whereas if you tell that guy, look, go and question something and find out, at least for the methodology, you can give him the mark. Whether he's learned how to do the method, instead of just, copying some other fellow's work and then saying, this is a continuation of so-and-so's work, filariasis in Chettinad was so much. Hey, who cares, man? If you've done something for the filariasis, it's a different story. But if you're going to give me the same information which could have been in a newspaper, what is the difference? No, it's very important, Kanak, that we follow Chandramohan's, remit of somehow making sure that we have some research in India. If we start in a small way, it doesn't matter. If we can have research fellowships with the college, we will try and facilitate that. We can use the Global Surgery Foundation, which is a part of the college. I think Sai was in Global Surgery. He still is in this Global Surgery Foundation committee, to see if we can apportion some money. If there are some young guys who want to do this, we can probably bring them across, giving them a bursary to spend 2 or 3 months in some lab and see. We don't want every Tom, Dick, and Harry. We want 2 or 3 guys who are really dedicated and committed. Because you see, India is so far behind in research. I can say this to this gathering, we are very, very, very far behind. You look at the index medicus, you look at the PubMed from India, a country with 1.3 billion, the number of research papers in peer reviewed journals is small. Look at the Japanese. Every day they're putting out a paper. You see, we need to see, the whole idea of research is to inform. We've got so much of pathology. We've got so much of clinical stuff which we do. I'm sick and fed up of people standing up and say, I've done 5,000 operations with no deaths. Very good. Thank you very much. But why did they not die? You're not telling me. How did you choose those patients? If you've chosen those patients that they didn't die, tell us so that we can learn how. If another guy stands up and says, I did 1,000 patients and 900 died, I need to know, why did that 900 die? Were they all very sick patients? What grade of illness did they have? Is your practice in such an area where there are people who are elderly, who are very ill, they present to you? That information is more important. Anyway, we can talk till.
I think all good things have to come to an end. And now let me thank formally from my position. And somehow, some part of near future, we would like to have a collaborative academic program having few speakers from the RCS or one of the institutions of NHS and ASI of the Chennai. We would love to have a collaborative program, not a very long program, maybe for a couple of hours, having a thought process. Maybe this contentious issue of sharing research concepts, how to initiate surgical research, those type of initiatives are the most sought after by various postgraduates. And I have many questions cropping up on the YouTube chat box also, where people end up asking, sir, if we take up a 8-year course, we have, in US, I believe 1 year or so they spend on research of the entire residency. I'm not sure whether it's mandatory. Many universities, as part of the curriculum, they are made to spend 1 year on the research side, and only maybe on-call responsibilities are given. Rest of the entire day they spend in the lab. Do you follow that system in the NHS is one of the questions.
Yeah, see, what we tend to do is we make it a mandate that you must write papers and get involved in clinical research. But we are more liberal in saying you need not necessarily do an MD or a CHM to continue with your training. But if you have the motivation to do a postgraduate study in academia, we will put you out of the training program for the 2 or 3 years for you to do that completely and come back to the training program. So academia is not thrust down your throat. There is a certain amount of academia that you have to do, which is mandated during that period in time. For instance, every year you should be doing some presentations in a national arena and in an international arena. The European Association or the British Cardiac Society or, European Association of Gastroenterology, whatever, in whichever specialty you are. And by the time you finish your 6 to 8 years, you've at least got 16 to 18 presentations and papers. That's a part of your training. You see? And then if you are an academic and you want to do something, you get out of the training program for 2 years or 3 years and do it. See, and then get back into the training program. Your training program, it's not as though 100% of your training program will be in academia. It'll be about 40% or 50%. And that, if you like, will be taken into account for your completion of training. You see, in the US, the residency where you do 1 year of dedicated lab work, all they get to do is to write some papers, get into, academic arena. But if you look at their data, only 30% of those guys who are in residencies actually go into academic programs and become, lab people.
I understand, sir. One last quick question before we call it a close. There have been always resentment from the residents. They made to work long hours. UK were the first few countries to curtail the working hours per week for the residential training. I would say I've been traveling across the globe. US, I think still residents work for long hours, that the 8 hours a day doesn't seem to work there. I'm sure in many of these busy departments across the world, residents end up working more. But there is a set of youngsters who claim, sir, we are supposed to work for 8 hours a day. We are supposed to work 40 hours a week. How do you match this? Because I'm sure this is a very practical question all the teachers would be facing now. How do you handle that? And what is the current situation in UK? Maybe a quick answer before we call a close.
Okay. See, over here, we were, if you like, restricted by EU laws. If I can spend 10 seconds
Please,
talking
please,
about
please.
that EU law was for long distance lorry drivers because these guys were driving, 12 hours, 14 hours a day, and they were getting involved in accidents in Europe. So this working for 40 hours, 8 hours a day was for lorry drivers. The stupid European Union made it a mandate to everybody who's working because of the Spanish, because of the French, because the French are lazy. They only want to work for 32 hours a week. So they made this 40-hour rule. And we got hit because in the UK, we take it most things so seriously that it went to Parliament and it became law. And when it became law, we got stuck. So even in medicine, it came into medicine. So this 40-hour period is during Monday to Friday, but we've got the on-call system. So in the on-call system, we had to make sure that we don't go more than a further 44 hours, so 84 hours a week. But now that we're going out of the EU, I'm sure that the British Medical Association, the General Medical Council, will try and do something about this because we are also concerned that some of the candidates who are coming out of the training programs are not completely fit for purpose. We are having problems with first-year consultants, second-year consultants, having trouble with their clinical practice, being suspended from their trust. So to root out that problem, we may be looking at the hours again. We are not in an ideal system at the present time, in my opinion.
Thank you, sir. That's more than a honest answer. I'm sure we also are on the same road, having similar challenges. And in fact, tonight we are going to deliberate with the National Board, Abhijit Sheth and Dr. Parnindra at about 1.5 hours from now. The current surgical education system in 2021, are we working on towards a redundant system or an evolving system? That's going to be the discussion as part of the IAG's program. With that message, I think we can go on, and I have to call the session a close. I thank all my co-leaders of the Chennai City branch for helping me to assemble this program. And I should put on record, Dr. Rajesh has been very kind enough to immediately say an yes. He only wanted time to take a call on the topic for choice. But then when we said surgical training and research, he immediately wanted a yes, I will take it up. So with that words, now I'd like the honor of inviting Professor Rama Chandramohan to tell a few words before we call a vote of thanks. Madam Rama, please. Sama Madam, are you with us?
On behalf, can you hear me, Kanagwel?
Very well, Madam. Can we
Yeah.
have it? Yeah, please.
Yeah, on behalf of Chandramohan family, I extend my gratitude to the ASI Chennai City branch. Thank you, Kanagavel, for honoring his, what shall I say, his overpowering knowledge and his zest for teaching. And I'm sure he's looking at all that's happening, and I'm sure he's proud of all the good work you're doing. And let me thank Dr. Rajesh. I think he had, if Rajesh is there, he's had very fond memories. I know he has been talking a lot about Rajesh to me also. And I feel that I know him personally. And I think it was a very good interaction, lot of doubts being cleared. And I'm sure with all the inputs, I think the young doctors would have benefited a lot. And thank your team, Kanagavel, once again for honoring his what shall I say, honoring his name. Thank you so much.
Thank you, Madam. Thank you. We will continue the good work what Dr. Chandramohan sir has instilled on us.
Yeah,
And
sure.
I should put on record here, after his demise from July, we have had 6 original publications being accepted at various journals of various work which has been doing in the last 2-3 years.
Okay. That's
Thank you, Madam.
excellent and very gratifying to hear. I don't think anything else would have made him happier. Thank you.
I don't know. Students continue to make him happy, I would say.
Yes.
And in fact, many of his data are awaiting to get accepted or at various levels of acceptance.
Okay.
And to put on record, all of 2020, like the previous academic year, that is from 2019 to 20 March, a total of 107 papers have been helped out with various levels of undergraduate, postgraduate, and super specialty by Dr. Chandramohan.
Okay.
And 56 international publications have happened under guidance. So that is the amount of zest he had. I would say the last few years, he has compromised on his clinical practice for want of promoting the surgical research and original work from India. On behalf of the ASI and the student fraternity and the surgical fraternity, we put on this on record. And we would invite the same amount of commitment from the teachers of current education system to spare their, I would say, a set of valuable amount of their hours every week for a dedicated research work for all the reasons which have been deliberated in the last 1 hour or so that Indian clinical material is appropriately researched and appropriately showcased. We have the big numbers, but then unless it gets published, it becomes, my own experience does not hold good for anymore in the scientific fraternity. So I'm sure the MCI and the National Board has mandated many requirements of minimum publications for various promotions from JR to SR, SR to assistant, assistant to associate professorship, and to the full professorship. So I'm sure these minimum mandates are no more considered as the bare minimum to work with. And let us surpass the standards set by the Government of India on various boards so that the next generation works on a robust platform of this generation's hard work, and they escalate or they ascend up or leap beyond from a higher level platform to play with, to be at par with the global arena. With that few words, I call this session a close. Can I request the honor of our treasurer of the Chennai City branch, Dr. Kannan, to propose a formal vote of thanks?
Thank you, Dr. Kanagwel, Chairman of Chennai City branch. First of all, I thank, and it is a proud privilege for me to thank Dr. Palababu Rajesh sir, who has given an excellent lecture about the training and career in surgical profession in the UK. In fact, in questionnaire sessions, we have given elaborative answers for all the questions. It is very much useful for all the younger surgeons and as well as all the surgeons. In fact, it is eye-opening for all of us to get trained in the UK, those who are having that idea. Because nowadays, getting training in US and UK, all younger surgical students dream. So that come to true whenever they are going to programs like this. And next, I thank the President and National ASI, Dr. and Professor Dr. Abhay Dalvi sir, who has presided over this function and inaugurated the function. And next, I thank my friend and our senior colleague, Dr. Sai Krishna Vital, is the Vice Chairman of Tamil Nadu and the Pondicherry chapter, who is bring this program and is instrument for this program. And I thank Dr. Kanalvel, who is Chairman of Chennai City Branch, who is taking a lot of pain to conduct this program. In fact, weekly is conducting more than 3 programs like this with international collaboration or national collaboration in the city chapter. So he is busy with all academic work, and he is associated with all presidents of the national and international associations. And I thank Dr. Chandra, he is the Vice Chairman of Chennai City Branch. Dr. Uttarakumar is Secretary of Chennai City Branch, and other office bearers, and as well as those who are participated in this program, who are having the eye-opening of the surgical career and as well as the program in surgical training in UK. I thank you once again for giving this opportunity for this excellent program, and it is one of the landmark program of our Chennai City Branch. Thank you once again.
Thank you. And I formally thank the friends on the YouTube who have been patiently listening to us. And I also thank the overseas friends. I'm quite surprised they also been contributing and asking questions in the YouTube platform. I could see at least few countries being listed in the YouTube: China, Singapore, Myanmar, and Vietnam. Friends are there. Thank you, friends. I'm sure Dr. Rajesh would have effectively cleared your doubts. And he is available in the RCS website. And he has mentioned the right departments for channelizing the right questions. As a vice president, he will be available to take or guide you appropriately or to direct you to the respective department for the help on various grounds you have asked for. Please feel free to reach me out if you have challenges in getting his mail. His mail is openly available in the RCS website, as well as his publications in the Research Gate, and the LinkedIn gives all the access to him. With that few words, I call this session a close with the permission. Chandrasekhar, you want to add something? Thanks. I call this session a close, and I warmly thank once again Dr. Pala Rajesh sir for contributing this. And we also formally request him for a research program. I would say not an initiative. Yeah, I would say a focus towards clinical research for surgeons in India will be a next possible program. Maybe in another 2 months or so, we will try to host and figure out a program. So let us give a direction for our surgeons on this original research, which is the essence and need of the hour. Thank you, one and all.
Sir, we will plan this program with collaboration with our MGR University and also with our colleagues. No issue, sir. We will do it.
And here to put on record, Dr. Chandrasekhar represents the National ASI, and he's quite active on the medical college teaching side. He's the secretary of the Tamil Nadu Government Doctors Association also. So he has connect to both the association side and the teaching side. That becomes a very important interface to initiate this program. I would say we'll give a fair time frame of 2 months or 3 months, and we'll have a proper structured 3 or 4 hours of intensive program. Let it be for the mid-level trainers who are in their 40s and 50s, where they go on to train the youngsters, because that is the focus group which we need to work on, where the next generation is effectively benefited. So with that request, I call this session a close, and I will officially write you, Rajesh sir, for requesting these initiatives with your permission. Thank you. And we wish you a good night. And Chennai City Branch has more exciting programs lined up in the coming weeks. We are going to have initiative on the World Cancer Day celebrations. It will be an awareness initiative. Dr. Chandrasekhar has been assigned the responsibility to create the initiative, number 1. We have the important Professor R. Nanjundrao program for undergraduates coming up. We are planning for an exclusive women surgeons program initiative, because women surgeons have been a very formidable resource for ASI, and women surgeons exclusive program is coming up. And we have initiatives lined up with various national societies and state branches, state chapters of the ASI. At least 4 state chapters are waiting to be lined up for this program. With this few information, I call it a close, and we look forward to have more fruitful interactions in future. Thank you. Jai Hind.
Thank you, sir.
Thank you very much.
Thank you.